Hi, my name's Bob Dyer. I'm the CEO of a group called Front Range Health Partners. It's a partnership between a couple of mental health centers on the Front Range, and we do cool things. The background goes deeper than that. Prior to that, I came out to Colorado to run one of the behavioral health organizations. I was incredibly excited about that because then the promise was integrated care. I came to that from running a company that did state legislation, Medicaid waivers, and set up and organized and oversaw prepaid inpatient health plans and integrated care delivery systems. So we set up ACOs and we set up PIPs and things like the BHOs. Prior to that, I ran a managed care company. Prior to that, I was the secretary for the state of Indiana in the creation of their mega agency called the Family and Social Services Administration, where they took welfare, mental health, substance use, disability, DD, and Medicaid, and put it all into a single agency. And in that capacity, that's really the role that I would like to speak to this group about. The opportunity to take an intact, mature system, and in the prior testimony you've heard about, at the local level, people will do whatever they can do to figure out how to string things together. The dilemma with that is doing it with the support of government or in spite of government. That's always the challenge. So suggestions from my attempts to take a mature system and organize it. What we started with was trying to figure out the lay of the land. The National Council for Quality Assurance identifies an outcome algorithm in which they talk about accessibility, acceptability, impact, and value. Those four concepts: accessibility, acceptability, impact, and value. Why? Accessibility. In public policy, one of the things that hasn't been mentioned, one of the things that's not likely to be mentioned in a setting like this, is the fact that most of us have crappy insurance. And having crappy insurance means that the percent of people with welfare, the percent of people with Medicaid, have more access to behavioral health services than people with a good insurance card in their pocket. And what we see is a problem with that. Again, public policy has some answers for that. We've seen the state of Minnesota say, if you're going to get a license in our state, you're going to do a proportionate amount of work with our public system. In order for you to make your unseemly profits out of the rest of it, then you're going to do some work to help us with the problems that people have. So there's options there that are creative. On the side of how we reorganize, part of what was hidden in that background and part of what you don't know from Indiana is I'm a big believer in the regional models. There's only a couple of different ways you can do public policy. There was a great book back in the prior century called Reinventing Government that talked about how you do public policy. There's only 4 paths you can take. I believe in regionalization. I believe in regionalization partly because healthcare is local, partly because only when you drop the barriers between the nouns that we have created, and I mean created, because if you go from state to state, the boundary issues on eligibility, on scope of benefits, it's all different. It's all over the place. We're the ones that create these barriers, create these silos that make it difficult to where if you came in this door, maybe they'd know about a benefit in that door. Who can navigate the complexity of the system? Part of what you see is that in our industry, people just shop jobs. They go from one organization to the next. Have you noticed they go from FQs to mental health centers? Have you noticed they go from mental health centers to substance use? It's all the same. It's all the same. So our issue is, let's get these boundaries out of the way. Let's try to figure out how the system can work. Our solution in Indiana, and I'm not advocating this, but our first thing was, let's assess the needs. Let's get good benchmarks. Let's look at who has access issues, who's satisfied, what systems work, what systems have a lot of noise. Every time you move people from one system to another, you lose about 15%. That's the cost of bad systems. Impact, my gosh, I am a recovering clinical psychologist. You cannot get 10 of them in the room and you're gonna come up with more than 10 outcome systems. I guarantee it. Everyone's got their pet. Who cares? Pick one. Monitor. Does it make a difference? And difference isn't nuances. Difference isn't little things. Difference is functioning. Difference is basic issues. Value. One of the things we're not talking about that we have to talk about is there's a finite amount of money. There's a finite amount of money. This isn't about adding more choices, more delivery models. This is about having the delivery models we have work. It's about doing things that make it easy. We have to consolidate. I watch the national debates on education, and it's like, how crazy. We have so little money, and we keep creating new ways to dilute that. Horrible model. We've got to make sure that we guard against that in any kind of reforms we do here. So, again, big message there. All right, enough probably. We can rattle on forever. The model I wanted to talk about in Indiana, though, and again, not as a model for you to think about, but to bring folks in to present that it's done many different ways. I love the organization this morning of all the committees. I think that's a great way to garner information. Our dilemma is, it's all people with the same experience. It's all people with Colorado experience. I'm a traveler. This is not the only place I've lived. I'm someone who's worked in over 30 states. There's a lot of different ways to do things. Back in Indiana, as we looked at our choices federally, we took education, welfare, we took disability, we took housing, we took Medicaid, we took mental health, substance use, DD, and we said, put it all together in one regional model. We took 120 some state administered federal programs, and we did what's called a presidential waiver above the level of CMS, so that we could have one standard of eligibility. We could have one standard of assessment and delivery. We could have one standard of outcome. And the result of that, which of course it was studied federally, was that we had an increase within 3 years of about 250,000 people accessing care. Part of that goes right back to this first part of this crappy insurance system. People with a benefit that they can't access care to. Because it's not just disabled folks that we have to be concerned about. One last point, delivery models, delivery systems. There's two aspects of care that matter. The first is immediate access. In our industry, when you're disabled, you are disabled. You're distressed. You need help right away. Getting people in the front door becomes the big deal. How much care they need? Most folks don't need much care. It's a small percent that need a lot of care. So the whole focus is, how do we provide high touch, low intensity service? Well, part of that, I'm an old guy. When I went through training, most of the training that they did for me was training on research that had been done in group models. I went out and figured out how to disassemble all that group stuff and make it individual. So instead of working with 10 people in an hour, I was successfully able to turn that around and only work with one person in an hour. Backwards. We need to see a lot more structured skill building groups for high incidence issues. Secondarily, people that are disabled severely need care management, and they need intensive care management. And again, the boundaries between physical health and mental health, we need to wipe them out. My excitement in coming to Colorado was, I thought, finally, I'm going to get to do serious integrated care. That is not the Colorado model today, and it's not the Colorado model in 2015. I hope that in 2020, 21, 22, sometime before I toddle off, that it is the model, because it needs to be the model. We know that if people have a chronic lifestyle-related illness, you could pick hypertension, you could pick arthritis, you could pick COPD, you could pick diabetes, and they have a comorbid psychiatric condition. You could pick depression. We know that it's going to cost about 3 times as much. Well, what are we doing about that? We know that with our Medicaid population, that a small percent consume the majority of expenses. Can't we open the doors better to make sure that we're dealing with both of those things concurrently. Enough. Hi.